Hey everyone, and welcome to another edition of the Heart of Innovation. You are getting a behind the scenes look at the taping of our show. We have a live broadcast on KDOW in San Francisco Bay Area, produced by none other than the Christie. And today we are talking about fighting for life and limb and the doctors and PAD warriors that were on Capitol Hill this week, looking to help patients who have poor circulation in their legs. So stay with us. You don't want to miss this very powerful episode.
Biz. This is AM 1220 KDOW, Palo Alto, San Francisco.
Sponsored by The Way to My Heart Incorporated.
Welcome to the Heart of Innovation, 60 minutes that could save life and limb, with new breakthrough ideas and innovation changing the healthcare landscape. Brought to you by Patient Advocacy Group, the Global PAD Association at padhealth.org, in partnership with Reflow Medical, the pulse of medical ingenuity. Here are your hosts for the Heart of Innovation, Emmy Award-winning journalist and founder of the Global PAD Association, Kim McNicholas, and interventional cardiologist and founder of Save My Piggies Health and Wellness, Dr. John Phillips.
Hey everyone, life and limb on the line on Capitol Hill this week as physicians and patients with a disease more prevalent and deadlier than most cancers combined, poor circulation in the legs known as peripheral artery disease. These patients were talking to Congress about early diagnosis and better treatment options for these patients. We're going to hear all about what was said. We have Dr. Bob Tahara here. We have PAD warrior Dawn-Marie, and also legendary Harlem Globetrotter Larry, Shorty, Coleman, all who were on Capitol Hill pleading with these congressmen and women to help bring early testing for PAD to the masses. So this is going to be a great conversation. Dr. John, I can't wait to get started.
Yeah, I mean, I think it goes without saying that the PAD, which it's estimated 200 million folks worldwide have it, is certainly this kind of disease. And we talk about this all the time, right? It's the bastard kind of stepchild. No one really, it's not super sexy, but it's there, right? And there's really high morbidity and mortality rate to it. Certainly underdiagnosed, misdiagnosed. We have folks on Save My Piggies all the time who have been misdiagnosed. And
yeah,
I was just listening to one of our, the CLI Society. We had some cases yesterday, and it was, yeah, we talk about cases, but we also talk about the fact that some patients just don't, they're not put in front of the right person to help them. And part of the advocacy, I know that Bob was a part of, is raising awareness, but it's also raising, in my opinion at least, raising awareness to our colleagues in the medical field and just the general population at large, which is why we do what we do. So I'm looking forward to the show. And as always, thanks for having me.
Fantastic. So should we kick off with a moment of inspiration?
I reckon.
Dr. John Phillips, spectacular, vascular moment of inspiration.
So this is a simple one. It's from a politician, Abraham Lincoln, one of our great presidents. And I was just trying to find something about not giving up and always kind of, quote, moving forward. And he's quoted as saying, "I am a slow walker, but I never walk back." So there you go. We got folks walking up on Capitol Hill, trying to walk forward, and maybe they made some small steps, big steps, who knows? And Bob will let us know, and the team will let us know, but at least I think they were walking forward.
Oh, I think so. What do you think? Dr. Tahara, we took a few steps forward this week, right?
I think so. The only, I think sometimes some of these activities get a little bit overshadowed by some of the other kind of political machinations that are going on in DC. And certainly a lot of the oxygen got sucked out of the room by some of the other hearings that were going on. But I do believe that particularly the stories that Dawn-Marie and Shorty brought to the congressional staff and the members was pretty powerful. And I think that we had a great panel up there. We had a lot of different societies represented, and I think we were able to get some information across in a relatively short period of time. And that's great. It gives you that awareness. And it's one more step in a lot of the hard work that we do behind the scenes, meeting with the staff and the members individually, and really trying to keep moving the sticks here so we can save more legs.
Hey, Bob,
so what was the purpose? Yeah,
Yeah,
I
go
was
ahead.
just
I was
gonna,
just going to
I
say,
think
give
we're
us your
gonna,
background a little bit and then tell
exactly.
us like how you got involved with this because it's super important for
Sure.
the audience to know.
So as some of the folks here, a lot of folks here who do know me know, so I've been a rural practice vascular surgeon my entire career. When I got done with my training, I came out to an underserved area in Western Pennsylvania, and I've parked here. Part of that was selfish. I'm an outdoors guy. I like to hunt, fish, and shoot. But part of it was being able to make a difference, and that's really what kept me in the area providing clinical care. The federal government publishes a heat map on amputation density. And when I came to McKean County, we had the darkest or the most dense rate
Yeah.
of amputations that they listed. After I was here for 5 or 6 years, that went down one full interval. And after the latest release, it was down another full interval. And really,
Wow.
that's because of the revascularization efforts that we make locally, which really accounts for the three-man group that I'm part of, me, myself, and I, in terms of trying to make this stuff happen. I got very involved with the Outpatient Endovascular and Interventional Society when it was formed because it struck me that this was the way we could get better access as things were consolidating vertically into healthcare systems. And the last 10, 12 years, I've just taken a progressively bigger role in trying to bring some of this clinical reality of underserved areas and populations to bear with both CMS and the Congress. So that's kind of how I've gotten involved in it.
And so there was this PAD caucus for a long time. It was together. They were trying to push what was called the ARC Act, right? Which would require insurance companies to cover early testing for people at high risk of PAD and hopefully also require a vascular assessment of everyone on deck for amputation prior to the amputation. Where are we at? Was that part of the initiative this week on Capitol Hill? Was that part of the effort?
Yeah, it was one of the asks. I mean, the Amputation Reduction Act, or the ARC Act, if you will, really had some good pieces put into it. And one of the biggest ones was actually to mandate some degree of vascular evaluation before a non-traumatic amputation was performed, or else the hospital simply wouldn't get paid for it. And again, sometimes a lot of folks misunderstand the economics of healthcare. It's really got almost nothing to do with what a physician gets paid because it's such a tiny fraction of the overall thing. And most policy ends up being derived because of the facility payments. So the ARC Act really had a great opportunity. Unfortunately, the PAD caucus, one of the true champions, Don Payne, passed away. And there were some other issues, and now it's being reconstituted again in a bipartisan fashion because saving limbs, and I don't care whether it's a so-called black inner city population or a white rural population or whatever, saving limbs is not a partisan issue. So it's really nice to see this PAD caucus come together, and the ARC Act was one of the asks that we had for action after we had presented the information and the stories that we had presented.
So,
And
Bob,
another, go ahead.
sorry, just I was curious for those of us that are listening and don't understand what it takes to quote get in front of Congress. Walk us through how you do that, and for physicians that are listening out there, whether it's vascular or whatever, who might have an interest in trying to get involved with this, how can they do that?
So I would very broadly stratify this is you've got three avenues to try and get involved. And I really would actively encourage any patient or any physician out there listening or viewing the stream to get involved on all three of those levels. So the first and the most immediate level is simply to contact your local federal legislator. They are very attuned to constituent issues. And again, regardless of where you sit on the political spectrum, our representatives are supposed to be working for us. So as a constituent, you not only have a right, but in my view, if you're a physician, you have a degree of duty to try and advocate for rational policies to provide for healthcare for the types of things that you take care of. So in the limb salvage world, that would be screening and diagnosis, and the ability to get coverage for primary care preventive interventions, things like diabetic foot exams and diabetes management and screening type diagnostics for populations at risk, and also to get the treatments because this is, to use the old baseball analogy, right? It's a simple game. You throw the ball, you catch the ball, you hit the ball, right? So if we make the diagnosis, if we throw the ball, if we actually catch the ball and we're able to start doing some preventative care maintenance, we still have to be able to hit the ball and actually treat the patients who are at risk of limb loss. So you can get involved with that very easily as for constituency. just being a constituent. The second level of
Is we're going to
intervention.
leave that as a cliffhanger, and we're going to tell you the number 2 and the number 3 when we come back right here on the Heart of Innovation on KDOW. Stay with us.
Sorry, guys. Hope I wasn't too long-winded.
No,
That's fine. What would be great is if John, if you could bring us back, you know, do say number 1, get him to do number 2, number 3, and then let's bring in, I know Shorty is not feeling very good. If we can bring him in to
Sure.
share his experience on there. And then, I know that Dawn-Marie has a lot to say, and, I'm sure it would be great to keep her, you know, for the duration because, we have a lot to talk about.
How long is the commercial break here?
Got about 1 more minute.
Okay.
Bob, can you tilt your camera
Got
down?
it. I just saw the note. There you go. Sorry, guys.
So
Okay.
really, Bob, it's just finding your local congressman or woman, right?
That's the primary level. And that does something. It certainly piques their interest because they do log these things, how much interest there is on it. And it does make a degree of importance when it's a physician doing it. But the second and third levels are really important. And that's actually getting involved in the political advocacy. And unfortunately, like it or not, that means participating in the funding mechanism. And that's something physicians are always really reticent to do. We've always kind of considered all these fiscal discussions kind of below us, but that's why we keep getting left behind. And you know, I've been saying for a long time, if you're not at the
30
table,
seconds.
you're what's served for lunch, right? So we got to get to the table.
Yeah, agreed. Okay. So when we bring it back, we'll just recap the first point and then we'll keep with the baseball theme since Kim gave me a softball here to hit.
And
Assuming I can swing
Dawn,
and hit it.
yeah, and Dawn, I do have, we're going to have a transcript afterwards of this too.
AM 1220 KDOW.
Welcome back to the Heart of Innovation. For more on today's topic, go to theheartofinnovation.org. That's theheartofinnovation.org. Once again, here's Emmy Award-winning journalist Kim McNicholas and interventional cardiologist Dr. John Phillips.
Welcome back, everybody. Happy Saturday. Thanks for joining us. We are live on KDOW. We are talking patient advocacy and getting in front of our elected officials to raise awareness for, among other things, PAD. So prior to going to break, keeping with the baseball theme there, Kim threw me a softball with respect to a tease. Bob, you had kind of given us one of the 3 avenues to get involved, one of which is contacting your local congressperson. But the other 2, as we were talking during the break, are a lot more important, it sounds like, right?
Yeah, I mean, being a constituent is really critically important, but it's not a force multiplier. What a force multiplier is, so now you're fielding the whole team on the field. You're not just throwing the ball back and forth in practice, is getting involved with formal advocacy. And that also is unfortunately linked to funding this, right? So there are political action committees, which in some fronts become a dirty word sometimes in the modern press. You know, people always talk about how terrible special interest groups are. But the reality is they're necessary. And, you know, if you take patients like Dawn-Marie and Shorty, who's advocating for them besides the docs who are actually taking care of the cases, and organizations like what Kim runs with the Global PAD Foundation? I mean, you really have a limited number of people who are doing this. So political action committees become important. And again, like it or not, we have, as physicians, have tended to not get involved in the funding mechanisms. So we've been left behind oftentimes in advocacy, whether it's for making sure that we've got stable reimbursement patterns so that we can treat these patients, or whether they actually get funded for these different screening and primary care initiatives. And if you look at maybe the other industries, the legal industry, the defense industry, manufacturing industry, I'm not casting aspersion on any of them, but they've been far more effective because they're far more willing to contribute money to those causes.
Yeah. And we have some of the patients that are actually here. We have Shorty and we have Dawn-Marie. I want to bring in Larry Shorty Coleman, legendary Harlem Globetrotter. So excited to have you. And this is Dr. John. You won't believe that this is the 100-year anniversary of the Harlem Globetrotters. So it's actually a really special year. And so thankful to have Shorty here. Shorty, tell us about your experience on Capitol Hill.
Yes, good afternoon once again. And
Hey, Shorty.
happy Valentine. I
Happy
tell you.
Valentine's.
Yes, Capitol Hill was a thrill for me because that's my hometown. Believe it or not, I got away from the cold weather. I'm glad we was indoor doing it. First of all, I like to just say that Dawn, you did a great job. I learned some valuable things from listening to you as well as many
Oh,
of the doctors on the panel. However, I could tell we had moved the people in the seats that was there because it was almost to the point like they was paralyzed to the fact, whoa, could this be me next? I got that kind of feeling. But for me, it's not going to help me because my leg is gone. But if we can help the next 1,000 individuals to understand, go get checked, go get screened. You know, we have primaries. You tell a primary doctor, oh, I have a pain in my leg. He or she might take you serious and send you somewhere to get help. But as a patient, Larry Shorty Coleman chose to go to the emergency. That wasn't the greatest advice for me to go to the emergency. I was better off contacting a vascular doctor or specialist that Kim refers me to now that PAD is in my good leg, so to speak. There's no easy way out of this. And I would just like for the people listening, don't take for granted it's just a cramp. Because I've played since I was 11 years old, the sport of basketball. If you're in shape, you don't get cramps. You get either a torn ligament or you pull a hamstring of that nature. However, I would have never dreamed that I would lose my limb. But now that we're in position to be on Capitol Hill is the greatest thrill. Somebody in that room is definitely going to want to move forward with us with this. But we do have to do more. That's one event. One event doesn't open up the can of worms that's going on. But I'm so glad we had the opportunity to share it. And I don't want to take up all you guys' time.
No.
Because I've lost my, yes.
You're doing great,
I lost my
Shorty.
temptation voice because of catching a cold. But however, I wouldn't miss this for nothing in the world. So if you have any questions for me, I can tell you. I just got multiple calls from family members, friends who have lost both limbs, lost 10 toes, and a friend that I played high school basketball with slipped on ice, and the doctor told him, we have to amputate your leg. How ironic is that? So just to give you a little scenario on it,
Shorty,
we got a lot to work on.
Shorty, can you hear me?
Yes, very well.
Good to hear your voice again, my friend. Can you just share with our listeners what it's like to, sit in front of our legislative officials? Because, a lot of us, I think, in our minds have a vision of, a camera, and you're sitting against that, you're on that table and the microphones are in front of you and they're asking you questions. Is it truly like that? Or were you able just to kind of give was it an open forum?
For me, they made me feel very comfortable. It paid off to have individuals that were so smart to know that didn't have limbs lost, to understand, to give us the time to speak on it. And I'm not intimidated because of the fact that's why you go to school, to get up in front of a class. But when you have to get up and speak about a health issue, and I'm willing to help other people, it made it easy for me.
And Shorty, for you, you were saying that you played basketball all your life. You're very active. One of the messages that you wanted to send to Congress was this is not a lazy person's disease, right?
No, it's not. And it's not African-American disease. It's a nationwide disease for any human that's not eating right, smoking and drinking. We can't just pass that off on the black race because anybody can lose a limb.
Yep, but here you were someone who was very active. You thought you were eating right, but you ended up with some genes, having some diabetes and other cardiovascular and vascular issues that were in your genetics. And despite all your efforts to stay out healthy, eat right, and be active, you still ended up with PAD.
And believe it or not, Kim, you would think I've been around the world. I had a chance to eat great food in each country. How ironic is it that what's good and what's bad? But I know from the African American side of it, my mother and them ate greasy food, drank liquor and beer every weekend.
Oh,
If
wow.
I didn't get paid to bring them this, go in the room. Well, I don't want to go in the room because I want to be nosy. So I do as they say. But chicken, potato salad, a sweet potato pie, apple pie, and they smoking like crazy. I said, "Woo-wee." I only knew this when I got older. But it's a dangerous thing, man. All I can say is I hope from Capitol Hill, not too many people raise their hand to say that they have family members that lost a limb. But I can express to you, without global PAD association, a lot of us would be dead right now. I hate to say that, but that's very true.
Yeah. You know, we
So
fight every day.
each one of our voices is very powerful to the people out there listening. Don't
Yeah.
take it like we just blowing smoke.
Nope. Hopefully they'll take you
Yeah,
seriously. We appreciate you so much, Larry Shorty Coleman, for raising the voice of the
yeah,
patient
well,
on Capitol Hill.
anytime. We
Thank you so
we gonna
much.
definitely have to get together again, and I hope and pray that we can have a amputee marathon for those that's able to walk. Those that's in a wheelchair, cross the line and at least stand up out of your wheelchair. That's my
Yep.
wish.
Hey, Dr. Tahara and
All
Dr.
right.
Phillips, let's make that happen,
All
okay?
right. All right.
Well, coming up next right here
Thanks,
on the Heart
Shorty.
of Innovation, we're going to hear from Dawn-Marie, also a PAD warrior who spoke on Capitol Hill. We're going to hear her story next right here on the Heart of Innovation on KDOW. Don't go away.
All right, Don.
Thank you, Shorty.
Yes, ma'am,
Shorty,
dear, anytime.
Shorty, you
Appreciate
just
it. I'll
made a
let you.
good point too about like not necessarily blaming the patient for the problem, right? I think especially with the onslaught of diabetes that we're having, this really is changing the demography of this disease. So different patients are getting it now. And John and I both see
Yeah.
this where a lot of times you don't get the warning signs with these diabetics. They don't have claudication first, which is, a
No.
real problem. And then we've had this whole nihilistic trend towards never treating claudicants, which isn't correct either. So it's kind of layered there. So you did a great job, Shorty.
Yeah.
Appreciate that.
But how is it? This is the one point I don't understand. How is it that we can support HIV and advertise that and be screened for it, get tested for it, but you ignore the fact about a vascular problem?
Great point.
Yeah, I hate to say it, but and I've said it before, and I don't think sexy is not the right term, but it's just not it's the same thing with cancer, breast cancer, for example. I mean, obviously a deadly disease, but there's the lobby must be stronger. There's just a lot more, it's in your face, and PAD is not in your face.
Yeah.
Most people don't even know what the acronym stands for, let alone the disease.
Most people think, most people that I explain to what PAD is, they think I'm talking about a pad that you come to. I say, well, this pad you won't want to lay down. Not when you get introduced to phantom pain and wake it up, like Don said, can't even go to the bathroom without wetting on yourself if you don't leave in time to go take care of these things. Man, it's deeper than what anybody thinks. They can look at you and say, "Oh, poor Shorty. He played basketball. Now he lost his leg." Not poor me. It's poor you if you let it happen to you. So with that said, I'm going to listen to a little bit of what Ms. Dawn is going to say because she's very inspiring. You guys better get ready.
Yeah.
Dawn, your phone
wait.
overheated. Are you okay, Dawn?
Yeah, I had it. I'm in the car. I'm in the car because I'm at my mother-in-law's house. So, and I had it on the charger, and it overheated, and then took me out of the video. I'm like, oh my God, I think it's my turn to talk.
Ma'am, can you please not say it was in the car? It was in the car.
It was in the car in the Harvard yard.
Yeah.
You guys are hilarious.
All right, are we
So
back?
the next
man,
segment,
now?
our third segment's only 5 minutes and 36 seconds. So just
But we
everybody-
have
Well, I
Yeah,
only
but
had
Dawn-
5 minutes on Capitol Hill, so if I
But
guess-
Dawn,
All right, well, you can
30
get it.
seconds.
hopefully you can just plan also to stick around for we still have a whole other segment that's
Yeah,
like
yeah,
8
yeah,
minutes after that too.
Oh, okay. All
All
right.
right, Dawn,
So
I didn't want
there's
to be
plenty
rude.
of time.
Yes, I didn't want to be rude and not listen to you because we are family now.
Oh yeah, we definitely are. Sure are. And we're gonna make some change. We sure are.
Yes, ma'am.
Because you only make change with the truth. And sometimes it has to be the hard truth.
KDOW.
Welcome back to the Heart of Innovation. For more on today's topic, go to theheartofinnovation.org. That's theheartofinnovation.org. Once again, here's Emmy Award-winning journalist Kim McNicholas and interventional cardiologist Dr. John Phillips.
Thanks for hanging with us today. Let's continue the conversation. Dawn-Marie, you were on Capitol Hill. You want folks' piggies saved, and you're a PAD advocate warrior. So tell us how that went. You said you only had 5 minutes to share your story, but it's my understanding you made an impact.
Yeah, I will say that as I was looking at everybody while I was talking, I did see that pretty much everybody in the room was engaged when me and Shorty were talking. Sometimes, yeah, the hardcore facts that they were representing at the beginning, may catch some people, but I could see that once we talked, like I said, the truth. It's the true reality of what we face every day as an amputee. None of it's made up. None of it's exaggerated. It's the cold truth. Sometimes it hurts. Sometimes, people don't want to hear the truth. And I get that. I really do. But, sometimes it takes knowing the truth. It takes education to help your own self out sometimes. And like I told everybody there, anybody in this room can lose a leg at any. You could go right outside right now and get hit by a car and then have to live your life without a leg. So it's not everybody. Like disease doesn't discriminate, so it can happen. They say, yes, it happens more with people of color, or it can happen more with men or with women. But I feel like nowadays, any type of disease can strike anybody at any age. My daughter's 10, has lipoprotein little a, something you don't see in children. Well, there you go. She has it. So, things need to change. And I feel like that's with anything, not just with PAD, with any type of diagnosis of any disease. We should all have the right to be able to diagnose it early and get the best care we can. And I feel like as a whole country, if we're represented as the United States of America, all the laws should be the same. All the knowledge should be on the same point. Like I did show them that I traveled from Virginia to Boston to get my care because Virginia is now just testing for PAD. I lost my leg 5 years ago. So why are you now just testing for PAD? I mean, everything I said in my speech that I shared with everybody previous to this was pretty much every point I got out there. I wanted to give them questions, because what I wanted them to go home is when they go home at night, they're going to remember me. They're going to remember Shorty. They're going to think about everybody else that walks around, like I say, roll around, because I was rolling around Capitol Hill. I wasn't walking around Capitol Hill. So when you were saying it earlier, I was giggling because I was correcting you behind the scenes. We rolled into Capitol Hill. So we rolled up there proudly. I think we did a great job. And like I said, we made an impact on the people that were in there. I can't say who the people were that we were supposed to be impacting. That was unclear to me because I've never been to one of those before. But I basically gave them the questions on these thoughts. Like, when you go home today, I want you to be able to, when you go home and you leave from this building, even the access, there's still snow on the ground. Like, I want you to think about how you go out and get to your car versus how I have to get out to my car. And I explained to them like that I crawl on the ground like an insect, because if I can't do something in my wheelchair, nor verse can I do something hopping safely with my walker, I will get down on the ground and I will crawl. Now coming to crawling comes to take the you know, the ways to learn how to crawl. Like on the ground, I wear a trash bag so my clothes don't get wet. But I tried to explain them to like most of the things you do in life with your two legs is by instinct. You just go and you do it. Everything I have to do is either learned through rehab or learned through personal trial and error. And sometimes that takes pain because you fall. You know, like being an amputee is not easy, but I wanted them to go home with the everything I said. I want you to think about it when you go and take your child to the park. I asked how many in here have children? Like when you take your child to the park tomorrow when the nice weather comes along and they say, Dad, Mom, can you push me in the swing? You walk right over there and push them. Well, I can't, because if there's wood chips on the ground, barriers, you know, there's going to the beach. We used to go all the time, all summer long to the beach. I can't do that anymore unless I have someone to pull me on a blanket down the sand. And then if my kids want to go in the water, do you think I want them in the ocean by themselves? Where mommy, who used to swim like a Olympian, can no longer jump in that water and save you because I can't even get down to the water on my own. Like there's so many things in life that is now trial and error. It doesn't come just with instinct anymore.
And we have just 30 seconds left, and I just wanted you to and one of the things they might be asking is, well, it's been 6 years since you what more than 5 years since you've had an amputation. There are a lot of
Almost
doctors that
5.
think that you're going to get a prosthetic, like no big deal. You're going to get a prosthetic the moment you have the amputation. Within a year, you'll be walking like no problem. You're
And
young.
I did say that. I said that to them. Stop promising. If you're a physician or a surgeon, stop giving the false hopes of walking within the first year, because I'm almost 5 and I still don't walk.
Well, coming up next right here on the Heart of Innovation, we're going to hear more from Dawn-Marie. She has more to tell. So stay with us right here on KDOW. Don't go away. And we're just joined also by Dr. Klein, who just literally saved a piggy just now. He just got out of a procedure. Thank you, Dr. Klein.
Thank you.
Where is John? And Dr. Klein, can you turn your phone sideways if you have the ability?
Yes, I do.
Oh, perfect. Dr. John, where are you?
Right here. Where are you?
Do you want to loop in Dr. Klein and then get back to Dawn-Marie, or should we, let Dawn-Marie?
Why don't we finish up with Dawn-Marie? Can you give us like 2 more minutes, maybe? What's the 4th segment here?
6 minutes.
6 minutes. Dawn-Marie, can you give us 2 more minutes?
What you're talking about the expectation of walking after amputation is pretty important too, Dawn-Marie, because that's kind of the traditional teaching. But I think most of us that do limb salvage work find exactly what your experience is. It's a very, very small minority, particularly of above knee amputations, but even the below knee amputations. Once you get to a major level amp, it's really, really tough to do the rehab. And I don't think people get that. They blow off the severity of that. And they don't count that into the cost either, right? This is a problem. The human cost here oftentimes gets overlooked. And then we have these stupid arguments about overutilization of limb salvage procedures, where really it's probably the exact opposite. We're still not doing enough of them.
That's with our numbers. And I don't know, Dr. Tahara, did I ever share with you the numbers that we have from our hotline? You might be interested in those. I should share those with you.
Yeah, that sounds like a whole nother conversation for us to have and really publicize. I mean, I'd love to take a look at what you've been getting from the hotline.
Yeah, it's ridiculous. I shared it at Viva. They published it, but no one really did much with it because I spoke at the Leaders Forum. And then I just presented at BD. I thought it might be something. I didn't know who to ask at OEIS, but it might be interesting for OEIS to present the numbers there. But it's not what people think. It's literally even above and beyond. It's like 85% where patients are not getting anyone to do anything prior to the amputation. And then 35% are told it's just because of diabetes, and 100% of which, when we go to get them tested, 100% of those patients who came to us, of that 35% who were told only diabetes, it was PAD. And what percentage do you think we ended up either mitigating a major amputation or preventing amputation at all? 100%.
Once you get them to somebody, yeah, once you get them to somebody who actually does true limb salvage, right? But you have to be willing to go below the knee or inframalleolar and do those kind of very time-consuming reconstructions. And not
Yep.
everybody's capable of doing that. Or
Yeah.
they need, honestly, a surgical bypass in some instances, right? I mean, that still holds true.
Yeah, and Dean brings up a good point. There was his scientific partner, Jim Ladishglax, I can never pronounce his last name, lost his right leg below the knee and then his left just a few months later while he was in rehab because the other leg turns in a lot of these patients right away.
Well, I mean,
Well,
and
the disease
Dawn-Marie,
burden's always bilateral.
yeah, and Dawn-Marie,
Yeah.
you're 5 years out from yours, so you've kind of beaten the odds, frankly, because the mortality rate is pretty high.
I will tell you why, and I'm going to tell you why, because Dawn-Marie lost her legs, but lost a leg. Dawn-Marie did not lose responsibility. I still have young children. I still have to go to the supermarket. I was helping my mother. I was helping
You have a purpose. You have a mission.
Yes, like I have to keep going. And she told me because my right leg is still diseased and they're afraid to touch it because of what
30
happened
seconds.
with my left, that to be honest, we're going to keep it as healthy as we can. And I use it in everything I do. So
So we're going to take it back to you, Dawn-Marie, okay?
He struck
Yeah.
a less aggressive,
And then we'll bring
but
in
still
Dr.
firm
Klein.
tone on Saturday about the Trump administration's intent to reshape the transatlantic alliance and push its priorities after more than a year of Trump's rhetoric allies. This.
AM 1220 KDOW.
Yeah, Kim, Jim just gave up.
Welcome back to the Heart of Innovation. For more on today's topic, go to theheartofinnovation.org. That's theheartofinnovation.org. Once again, here's Emmy Award-winning journalist Kim McNicholas and interventional cardiologist Dr. John Phillips.
Thanks for joining us, everybody. As we reflect on this show, I think it goes without saying the gratitude that I have for the folks that are brave enough to speak to Congress regarding their disease process as it pertains to peripheral arterial disease. And nobody is more worthy than Dawn-Marie, who's lost her leg. But, we were just talking during the break about the high mortality rate after a major amputation. You beat those odds, and you were saying, I don't have a choice. Like, I have a purpose in life and I have to keep fighting. Is that some words that you shared with our elected officials when you were on Capitol Hill?
I did. I because you have such a short period of time to talk, like I wanted to get the major points out. So I did say that. I said that, the surgeon took my leg. He didn't take my responsibility. I still had kids to go to. Like I could have went into the extreme. I have 6 dogs, 6 chickens. Like those are all things that depend upon me. My 10-year-old is also intellectually disabled. So she takes up a lot of my time with trying to get her from, she's now supposed to be in 5th grade, is on a 1st grade level. So I'm trying to fight legislature with that because we still have to follow the laws for the grade she's supposed to be in with the education she's getting. So and that's why I said, there's so many things to fight for out there. But we need more people like me. I can't be the only one. Shorty can't be the only one. We need help. And I feel like the more voices, even if you can't come, like the next time that I go to Capitol Hill, I would like to go with a stack of letters from other patients or something to show like I'm not the only one out there. Because they could look at me and be like, well, I'm sorry, but a lot of them in there look like sophisticated, had a lot of money. I'm coming in with tattoos, nose piercings. I made it show that I do have a college education. I'm just as educated as them. And I wanted to show that I'm not just some,
You worked in an operating room. You worked in an operating room.
But right now, I am in that lower bracket. I am now in that the poor bracket where these are the people that aren't getting the care either, because of where they live in the areas. I'm not even in the rural area of Virginia, and I still can't get great care. I'm not saying there are not great doctors, but where are they? Like, where are they? You have to travel, and not everybody has that access. Like, I wanted them to see me, like with my nose piercing. I came in there with it proudly. I don't care if they saw my tattoos, because no matter what I am, and that's what I wanted them to see, no matter what color skin Shorty's skin is, whether he's a male or I'm a female. Maybe none of you, like Shorty said, we asked, does anybody else have any amputees in their family? Not one person or knew anybody could raise their hand. So you don't know what we're relating to. And I made sure that they never say, like, I understand. When you're talking to me, you don't understand. You will never know what someone else is going through until you're facing that same thing, whether it's cancer, whether it's diabetes, heart problems. You don't know. You just have to listen and be educated. And that's what I wanted people to hear. Like I said, again, it's the cold truth, the truth facts. After seeing what my speech did and how many views that speech got on Facebook and how many shares, I'm almost determined to do a TikTok video to have somebody follow me around my house and everything I do with the camera, so I could show you how it is. Because I can tell you all I want. I can sit here and read this thing I said, like I did the other day, and say how it is. But I really think it takes like me to go there and tell you the raw truth of how it is for me. Like I said, I pee myself. I told him my boyfriend has to come home from two jobs to take care of us. And if I have the flu and vomited on myself, or, had the other fluids come out another way, he has to help clean me, because I can't do it by myself as an amputee. I can't go sit down and back on the chair that is going to get dirty, that I got to sit on all day long. Like I said, somebody has to be out there to say the actual truth, and that's me. Like, I'm not going to sugarcoat it, because this is what I go through. I mean, you could say I'm embarrassed to say, but why should I? I'm not embarrassed of who I am. I'm a person with no leg, and this is what I go through. This is the battles that I face, and I'm sure a lot of other people face the same things. Without a leg, or even with two legs, with this disease. Because I know how it was before I lost my leg. I couldn't walk. I had to sit on the floor, like I said in my speech, and cry in public at 45 years old back then, like 44 years old. It's embarrassing. It's degrading to have to sit on the floor. Now I don't care. I'll sit on the floor and crawl like an insect. And I said that many times to them.
With as many times that you sat on the floor, no one ever cared about your leg cramps. Even after you had a heart attack, they didn't care about your leg cramps. What if Congress would have acted sooner and said everyone at high risk, which would have included you, would have been tested for PAD? How would your life be different? Yeah, I can see you nodding.
I wouldn't have to do all those things I say, right? I would be doing everything everyone else does.
Thank you so much, Dawn-Marie. You just inspire me every day. I appreciate you so much. Coming up next right here on the Heart of Innovation, we will have more on this topic and some closing thoughts. So don't go away. Stay right here on KDOW. Ooh, you're going to make me cry. And I'm wondering, can we get final thoughts? We can continue the conversation for a few more minutes after, if you'd like, so and I can edit it into a final video that we put up. So Dr. Klein, we don't feel like you're going to get cut short, but the last segment is only 4 minutes. But if we have additional things you'd like included in the final video when I edit it together, as soon as this hard stop at 4 minutes, we could take a few minutes afterwards and get a few additional thoughts, because it's still an important topic.
No problem. Sorry for the delay.
That's okay. You're allowed to save those piggies.
Well,
kind of important.
Call, but I had to come in here today to do this. So,
Dr. John, do you want to take us back with, I mean, I think it's so amazing that here Dr. Klein has joined us from Capitol Hill to go and, to the operating room, saving those piggies on a Saturday.
Indeed.
Okay. And this is usually just a 30-second. Sorry, Dr. John, I miss. So Dr. Klein, you're still in Atlanta, right?
that's correct.
Nice to see you, sir. How are you? Thanks for joining us.
Thank
Yeah,
you.
do you guys know each other? Dr. John is over in Columbus.
Okay, wonderful.
Welcome to the show.
Thank you.
Okay.
Whoops. There's Dawn. Dawn, I just put you on mute. And you're good. If you want to run back inside, we appreciate you being here, unless you had more to say. But you really had an impact. I was talking to Dr. Tahara, and I think it would be really incredible to, and I can get a proposal ready that maybe you guys can send out, and we'll just do a face of denial and a journey to diagnosis every single week.
I have a question before we go back. How often do you guys go up to Capitol Hill? Like, how often do you voice this? Like, how do you even do this?
So it depends a lot, Don, on what's going on. So for instance, I spent more time in DC in September than I spent in any of my clinical sites. And that was all in reference to the reimbursement stuff and trying to make sure that there was enough funding that we could actually afford to do these types of procedures. So it waxes and wanes depending on what the issue is. And unfortunately, some of it is reactive. We're not always as proactive as we would like to be because things pop up and then we have to fight those things before they create a real divot in access to care. But the PAD Caucus thing was a
30
proactive
seconds.
thing.
Yeah, we should talk about that after the show because I'm curious how you navigate those waters because you're leaving your practice and that's income, right?
Not well, John. Not well.
Yeah, no.
321 now at 800-348-0933, 800-348-0933. That's 800-348-0933. Paid for by the Detox and Treatment Helpline.
1220 KDOW.
Welcome back to the Heart of Innovation. For more on today's topic, go to theheartofinnovation.org. That's theheartofinnovation.org. Once again, here's Emmy Award-winning journalist Kim McNicholas and interventional cardiologist Dr. John Phillips.
Ladies and gentlemen, we only have about 4 minutes left in this powerful show. I want to introduce and bring Dr. Andrew Klein on the air. Dr. Klein, you too were on Capitol Hill, but also just right now, I think, finished helping a patient, maybe saving some piggies. So welcome, and give us your thoughts of how you think the caucus went.
I think, thanks, John. I appreciate it. I think any opportunity to be in Congress is a good opportunity, mainly to raise awareness. I think, as we know, as I said during my talk, probably a third of Congress have PAD and don't even know it. And so I think anytime we can get, in their heads and at least on their platform, it's a good opportunity. And thank you to everyone, Dr. Tahara and the whole crew for coming up there. It's obviously it's a challenge, but I think the biggest thing was listening to Dawn-Marie and Shorty. That's just, it's incredible to hear their stories and hear what they have to endure every day. And it's partly why I'm here.
Do you think that it resonated with them, or were they giving you lip service like we often sometimes feel that they do?
No, I think it did resonate with them. I think, the Congresswoman who spoke was, she was very well briefed on PAD, and I was quite impressed, her staffers and everything. I think they really made an impact. And at the end of the day, it's just being consistent and consistently showing up. That's going to be what's important. I think together as a coalition and as a large group that believe very passionately about this, we can go a long distance. We just need to keep showing up and keep working on this and understand that there are all these issues that are in this field, and it's not a rare, as somebody put up the slide, as we showed, our death rates from PAD are equal to that of cancer in a lot of ways, colon cancer, breast cancer, et cetera. So I think it's really important to understand that this is more prevalent than people think, and it really can absolutely ruin or take their lives.
It's incredible that you guys took time out of your schedules to go out there and raise the voice of these patients, because that's really what you're doing. It shows how much you care about people, right? Patients are people. When you closed up, share with us the closing thoughts. What was the message, and did you talk about next steps?
So I think, Wayne Batchelor from Association of Black Cardiologists really closed it up nicely. I have to say, he really did a nice job of wrapping it up and really looking at, again, the PAD caucus, ensuring that other members of Congress join that, and that, at the same respect that we also move to the Amputation Reduction and Compassion Act. That's going to be the critical thing, because we need to get that through Congress so that we can really make an impact in more patients.
Well, thank you so much, Dr. Klein, Dr. Tahara, Dawn-Marie, and Larry, Shorty, Coleman. Thank you for raising the voice of patients and for all of your courage speaking on Capitol Hill this week. Make sure you join us on YouTube right now. If you're listening on KDOW, youtube.com/the @ the way to my heart. We're going to continue the conversation and hopefully create the change that we all want to see.
Thanks for having us, Kim.
Thanks, Bob, for going up there to and leveraging for getting these procedures covered in September.
Well, what's amazing to me is that so many people misunderstand the economics of medical care, right? And unfortunately, a lot of the general public just thinks the physicians are kind of just overpaid dilettantes, and they don't. Most people don't understand how costly it is to provide this care. And it's a team sport. I mean, at the end of the day, Andrew, I mean, everybody's got to pitch in, whether they're, a hospital-based physician. Obviously, we had multi-specialties and multi-societies there. That voice is always amplified when we can do that, so that it's not parochial. And it really isn't anymore. I mean, limb salvage care is totally complementary because it's a spectrum.
Yeah, the vertical integration of healthcare and the insurance agencies. I mean, that's been that's where all the money is. I wish people would understand that it's not the physicians. It's in the vertical integration of the insurance industry.
It's the root cause of this stuff, though, Andrew, which is just so fascinating.
So, gentlemen,
it's totally.
Gentlemen, explain that to our listeners. What do you mean by vertical integration?
Go ahead, Bob.
So vertical integration means large conglomerates that then expand to employ physicians, own diagnostic facilities, own treatment facilities, and own hospitals, and in some cases actually encompass the insurance payers. So the idea behind this was a vertically integrated situation would be more efficient. Well, we have seen exactly the opposite. What it does in every single documented instance is raises cost. And this is one of those unintended consequences of some of the things that came out of the ACA, which, while it was noble and well-intentioned on some fronts, the mechanics of this really spiraled out because of how some of these things worked. And so we've got this kind of complex overlay of regulation, which has served to do exactly the opposite of, I think, what most folks intended it to do. So we have states that have CON, or certificate of need laws, that chokes out competition. We've got a diminishing reimbursement pathway, which makes staying in independent practice like I'm in more and more onerous every year to be able to do that. And then on top of that, we've got this vertical integration, which then allows these large conglomerates to essentially control the market and then be subsidized to control the market. So the net effect of this is it actually reduces care, increases the cost, and it actually makes it harder to effectuate the changes we're talking about here to save patients' limbs.
Especially when it comes to insurance companies. Many of the insurance companies, what I think most Americans do not understand, own a pharmacy, and they own practices, and they have a pharmacy benefit manager that negotiates with pharma for cost. Those costs don't get put on to the payer. They get to put in the pocket. And so what happens is the pharmacy benefit manager then goes to farmer, negotiates that cost, then gets put back to, I don't know, say United Healthcare. And then they also own practices and they own the pharmacy you have to go to. There's all these mail pharmacies are actually owned by the insurance company. So it's all being generated by the big six. And I think the big issue is that people don't realize this. It has essentially become a monopoly.
But do you think that because, and this is John Phillips speaking, so take it for whatever it's worth, but at least in my experience, a lot of the folks that have peripheral arterial disease are somewhat on the margins of society. And I mean, do you think if we had a bigger lobby, like some of the other disease processes that do get the press, we would be more successful at this?
Well, I think, John, I think you're right. There's a large fraction that are marginalized and sort of the most vulnerable populations. However, I think if we just simply went forward and said, hey, AHA, this is great. You have heart disease in a lot of ways, and they're sponsoring a national PAD conglomeration. The reality of the situation is atherosclerotic disease, if it's in your heart and it causes an issue, it's a heart attack. If it's in your brain, it causes stroke. If it's in your legs, it causes peripheral arterial disease. It's the same process. So if anything, we should all be on the same, we should be just like physicians from different specialties working together. We should make certain that all our components that are looking at cerebral vascular disease, heart disease, vascular disease, it's all the same thing. We need to work together in Congress to make certain that we're raising awareness, because if you have atherosclerotic disease in your legs, I promise you, you have it in your heart and you have it in your brain, and probably vice versa.
And that's exactly what I said earlier. Why is this country, if we're supposed to be a country as a whole, why are we not all on the same page with healthcare?
Well,
it doesn't make any sense to me.
Money. The answer,
of course, everything in this country is about money. And what is the money the root of? Evil. Like, I don't understand. And like you said, everything is a monopoly. And the sad part about it is people like me who are now low, on the lower class side, have to suffer up to the hands of people with money. Like you said, the same thing. We have a prison down here that's owned by judges, that are judges that send these people to prison that just make their pockets fatter. Like, why are we like this as a country? It's disgusting, honestly.
So part of what John said, though, before Dawn really comes into play on this, because what's happened is there's a lot of ignorance about the disease process. I mean, what John and Andrew and I do is for people who don't do vascular interventions, it's a black box. It's kind of a mystery type thing. And that's even among the medical profession. And that's not because people are dumb. And that's not because people aren't well intentioned. It's they just don't know what they don't know. So raising this awareness like you guys have done has been really helpful. But the whole thing, I mean, we do spend a lot of time, rightfully, calling out some of these big insurance company conglomerates. But the problem has gotten a lot more difficult because as these hospital systems have become larger and larger, they've also posed a parallel, essentially, monopoly. And honestly, they just had some Senate testimony, and I think it was Josh Hawley was talking about trying to make everybody, quote, not for profit. Not for profit, large conglomerated health systems are one of the biggest scams out there. These places own billions of dollars of prime real estate. They disperse that. It's a named nonprofit. What nonprofit really means is preferential tax treatment. And so essentially the American taxpayers have been put in a position of subsidizing these monopolies, which is absolutely insane and the exact opposite of what we had intended when we did some of these legislative vehicles like the ACA.
And Dr. Tahara, I just want to add to what you said, because I had my eyes opened up when I applied for a grant from industry, and they sent me the wrong check, and it was to the wrong person. So I thought I was like, wow, they gave me a lot more than I would have requested. It was $100,000 check. But then I looked at who it was to, and it was to an actual hospital, a nonprofit hospital foundation for PAD testing, where do you think those patients are going to be sent? It's going to be sent to that hospital. And guess who's ultimately going to benefit from those patients getting tested? Not only the hospital, but the industry, the company that makes those tools to treat those patients. It's just like this vicious cycle. How is that even allowed?
Well, yes, what you just said is so true. But, let's look at another unintended consequence. One of the provisions of the ACA, so-called Obamacare, was to, quote, limit the profit of these systems and these insurance companies at 15%. So what happened? As the monies kept coming into these insurance companies and rates kept going up, look at what executive compensation did and look at what they're paying for. They're naming stadiums. They have private jets. They have, executives that are making 20, 30, 40 million dollars a year. Meanwhile, they are crucifying myself and John and Andrew for $2,000 or $3,000 to try and save somebody's leg when we're not even getting
Right.
at it. That's what it's costing us to do. So there's a lot of problems structurally with how this stuff has gone on. And, I think we have to be a little bit more thoughtful. And I think what should come out of this entire exercise is every time something sounds too good to be true, kind of like the ACA did, we got to take a step back and go, okay, what are the motivations? They're noble. How can we implement this? That's great. But I think if you, by any objective measure, we created a system in the last 14 or 15 years, which has made access to care for the types of patients that we take care of actually worse, not better. And that is mind-boggling to me as a patient and a physician advocate on how that can happen.
I still think one of the major issues as well that we haven't quite discussed is how is it possible that these insurance companies, that it's so acceptable for these amputations to be performed carte blanche, reimbursed, right? Whereas these revascularization procedures are criticized. I mean, it's just blowing my mind that insurance companies will pay for these expensive major amputations that are going to lead to rehab and wound care and this and that and the other thing versus a revascularization procedure. And they make these patients wait and wait and wait, and they're suffering, and they're calling our hotline in the middle of the night saying, I need some hope, I need help, what do I do? Walk me through dangling my legs, pacing, trying to get the blood back through to my feet. And then ultimately 2 weeks later, they ultimately deny it because the gynecologist gets onto a peer-to-peer and says to the vascular surgeon, I'm sorry, I don't think that this is necessary. It's just absurd.
There's two pieces to this, though, Kim. And the first part is this: amputation has been around since medicine has been documented. We jokingly, and it's a bit of gallows humor, sometimes talk about, quote, Civil War amputations, more related to speed of doing a procedure, because back then, how fast they could operate on those patients was whether or not they're going to die right on the table or not, right, from exsanguination. But the reality here is amputation's been around for a long time. Revascularization is really a recent technology. And anytime a new technology comes up and we start using it, the volumes of use go up. And unfortunately, there has been a knee-jerk response on the part of the payers and even within our own specialty organizations that anytime utilization goes up, they say, well, people are just doing it to do it or doing it to make money, or they're doing it, quote, inappropriately. And what almost inevitably happens as time goes on, the data finally catches up. And that's not the case. But I think it's important to recognize some of the ways that we have to salvage limbs now that weren't available when I went into clinical practice or were just nascent. All the endovascular stuff was just coming into being when I got out of training. Nobody did the kind of stuff we do today. And if somebody had told me 15 years ago, I'd be doing this in my office on a daily basis under local anesthetic from a pedal access for everything, I thought they were smoking crack. But the technology and the technique changes. And when it outstrips the policy, these are the mismatches that you see. So that's part of the issue. The second part of the issue is upfront cost, right? And they look at what a physician gets paid to do a below knee amputation, which is about $400 from Medicare. And then they look at what, quote, a revascularization gets paid, which is 12 or $1,300 on a good day. And they go, oh, well, we're going to try and throttle that. But they don't take into account all the other costs, the human cost, which both Don and Shorty highlighted over and over, and the actual overall cost. It's so much more effective cost-wise, even if we take the human cost out, which we should never do, to do a revascularization or multiple revascularizations compared to doing a major level amputation. But again, the insurance companies don't view that in the global, what's the total cost? They view it in a calendar year, a fiscal year, right? So if it's November, me trying to get revascularization procedures pre-approved, it's like pulling teeth. It's like pulling teeth because it's near the end of the year. They don't want to spend any more money. So those are kind of the factors that I think factor into why amputation seems to be, quote, more acceptable. And going back to what Andrew said, why it's so key to get the ARC passed, right? If we can disrupt that payment modality, then maybe we can start to intercede and make some changes in how that goes.
I think part of the problem too, that as I interpret it, is that we don't, when we explain what we do to other people who don't do what we do, it's it's hard for them to kind of understand the fact that it often takes it takes multiple procedures, and then that I think gets translated as, well, he or she's just doing it to generate more money. It also, a lot of what we're able to do in medicine, at least in cardiology, I can put a coronary stent in somebody and that stent will stay open for 15 years. Whereas work that I do in the legs, I tell patients, this is your first procedure, but it's not your last, most likely, and we need to keep an eye on this. That doesn't translate well. And then in the same vein, and again, this is just John Phillips editorializing, but there are a few bad apples that spoil it for the whole bunch. And when we are, and this is a system that CMS created, we didn't create it, but when you're, you're incentivized to some degree to do procedures that have high billing margins, well, more people are going to do it. And I do actually worry about the new CPT codes now, which I think are rightfully, we needed them. But, now when you can add on certain procedures where you couldn't, I mean, is that we have to police ourselves better, I guess is what I'm saying. And we have to explain ourselves better.
So the answer is yes, but I think the other part of that, John, is really, we have tended to concentrate on this concept of the bad apples. Okay, they're there. And that you can take that in law, medicine, plumbing, electrical, broadcast, it doesn't matter. They're always there. But one of the things that I think does really get missed in the equation is we really have a choice on how we're going to try and incentivize people to do things. Do more work or don't do more work. And if you look at every single other contemporary Western society that has much more of a, for lack of better terms, a modern democratic socialist type of a medicine system, Canada comes to mind. They do some things really well. The UK comes to mind. They do some things really well. But there are other things that don't, and they get pushed off to the side because there's no incentive for productivity. So we have a balancing act to do. The other thing that I think is always troublesome in that equation is a lot of times people concentrate on the outpatient operators, right? But the reality is there's not a physician in the United States who is employed that doesn't have a productivity clause in their. So the entire thing is designed to incentivize physicians to do more work. Now, is it better to do it volumetrically? Is it better to do it by complexity? And again, these are all questions that I don't think there are very clear answers to. But what is clear to me is we have to figure out a way to incentivize people to see more patients. And the way to do that is not to continue to cut reimbursement and make it tougher for people to stay in practice. Because if they get out of practice, they get them completely absorbed by these vertically integrated systems. And then that same problem we were describing previously just multiplies on itself,
But why is it that the bad seeds that are performing these amputations without a proper vascular evaluation, they're not getting the attention? It's the ones that are trying to save the legs that are getting the attention. Why do we keep ignoring all of these physicians that are literally, we know who they are. We have their amputation rates. Why doesn't the media care? Why don't our researchers at the university hospitals care about sharing those numbers?
So-
Why is it the revascularization ones that matter?
I think, Kim, I'll take because, certain individuals made it for the New York Times on a Sunday a few years ago about this exact same thing. And I think it's the story by media. The idea that, there's, I don't know, thousands of doctors out there that are doing amputations, but if we can single out the top 5 that are driving up costs, makes physicians look like the bad person. It makes these people look like they're doing this all for money. They're greed. Then you throw in the industry part and it plays this good story. The reality of the situation is that many of these people
doesn't happen.
Yeah, many of those people were spent a lot of time trying to save limbs. And yes, they probably had higher than, average this and average that, but they're good intentions more than anything else. And I think the problem is that amputations are thought to be just, that's what you do, no big deal. And as Bob said, we're changing to be like, no, that's not what you do. 60% of all amputations occur without an angiogram. That is despicable. Anyone, like, we are, even in our hospital system, are trying to set a complete paradox change here and basically have every patient that's slotted for an amputation be reviewed by 2 physicians. But
that's exactly what we're trying to do too.
it's a big issue because now somebody's looking, you have to be open, right? Because what if your partner thinks that you're crazy for amputating and they could do this or do that? Now you're going to send that patient to your partner, and now you're losing money. And so
You're exactly. So yes, that is, I think, one of the biggest problems. Hubris is an issue here because the people that get amputated, in my opinion, and I've heard this from reps around our area and then the state, that some of these folks that quote do PAD work don't do PAD work, but they do major amputation work. And so we really need to, if this is ever going to work, in my opinion, you need to break the barriers, check your ego at the door, and do what's right for the patient. Or, like what we try to do here on this and with Save My Piggies, is raise awareness for the patients and tell them, you know what? No, I'm not getting an amputation until I get X, second opinion, third, whatever it is. And it's sad that the patient has to do this, but unfortunately, that's the current state.
But John, again, I think that comes down to what I was saying before. I think our technique and technology is moving at a higher pace. We've got all kinds of options now that the 3 of us didn't have a decade ago or 15 years ago, or in some cases 5 years ago, to try and save some of these limbs. But not everybody is coming along with the technologies or
Correct.
the techniques. And that's just the stone cold reality. And then there's that double-edged sword, right? Do we hop on everything? I like to tell people I very aggressively apply new technique and technology, but with relatively conservative standards, right? Because there are some things that we do that are toys and they end up not working. And then we do spend a pile of money and time trying to do those things. But I think, you have to run that balance of being open, because what's again, the ultimate human cost if we get a major level amputation? It's what Dawn brought out. And
And
that's
we have Marcia.
tragic.
Marcia, go ahead.
My point, actually, the conversation has changed dramatically since I posted that.
That's okay.
It was about, the doctor was talking about nonprofits, and we have a local hospital here, or a network, Kettering Health, and they're just awful. So the CEO and his friends got found guilty of misappropriating, basically stealing $3.2 million. And that's only what they know for fact. It's nonprofit. It's through Seventh-day Adventists, which I'm not trying to be political or anything, but that's, who owns it. And I put a link to it. It's his name is Mansure. It's just awful. They're just as corrupt as can be. And then yesterday I get in the mail a thing wanting me to donate to their foundation. I have a private foundation and they want me, and I called them on the phone and I said, take my name off your list. They've raped our little community hospital that was on our tax ballot, that, our voting ballot, that it was used to be a community hospital, and it stayed on there for years, and they took everything out of the hospital. It's just incredible. And
Marcia, you're raising a huge point that I think is happening nationally too. We've seen that in rural areas where, as the vertical integration has gotten bigger and bigger for these nonprofit systems, particularly the small community facilities have been turned into just feeder stations for the larger things. Now, sometimes that's appropriate because you can't, like most rural communities don't have a guy like me sitting in them, right? Let's just be honest about that.
Right.
So sometimes you need to transfer things to places where there's more capable care, and then they have the ability to salvage limbs, so they don't just do an amputation. But having said that, care locally, or at least access to care locally, is just so critically important, especially in, again, as speaking as a rural guy. And we've watched this get decimated in the last 5 to 10 years. Again, I think there are unintended consequences. I don't, a lot of people say this is deliberate to try and do things. I don't really believe that that's the case, honestly. I think a lot of these were unintended consequences, but human behavior is what human behavior is going to be. And I just don't think continued vertical integration and loss of independent practice is a good thing for American patients.
And I actually just have had 2 patients, Dr. Tahara, in the past couple of weeks, just one this week, where the community hospital they said that this patient had a leaky valve in the aorta, and in the left ventricle, the problem was there was a big clot. So, but they didn't know when this person was brought back to the hospital whether the clot was there because they didn't have the ability to perform a TEE. And so, or advanced testing. So they're just letting the patient die in this community hospital. And that's really sad to me. They wouldn't transfer it. And by the time I got involved to try and get a transfer, the patient wasn't stable enough to be transferred. Secondarily, we had a patient over in Wisconsin, in the Milwaukee area, about an hour north, and there was a hospital system that had the larger hospital, and a couple hours away was the smaller community, a little feeder one. And the patient was on deck for a toe amputation. And the daughter called me in the middle of the night on our hotline at midnight, their time. And she said, my mom's on deck for a toe amputation at 8 a.m. And I just had a funny feeling, woke up, found you guys. What can we do? She sent her dad to the hospital literally just before 8, and they were able to stop the procedure because he asked, what about a vascular evaluation? The Society for Vascular Surgery says, hey, you should perform a vascular evaluation prior to any amputation. And the podiatrist said, well, yeah, you're right, but we don't have the ability to do that here. Well, why don't you have the ability to do that here? Because we don't have a vascular surgeon on staff. You'd have to go to the other hospital. Now, wait a minute. Here's a person on deck for amputation. I know you may think just a toe, but you know very well, right, Dr. Tahara, Dr. Klein, Dr. Phillips, that you take the toe, and if they don't have a proper vascular evaluation, it's not just the toe that's going to go. It's going to be the entire leg. Why do they not transfer? And we see this over and over again. So when you talk about these community hospitals as being feeders, they're not feeding. They're treating the patients there in so many of these scenarios with PAD. And it makes me really sad.
That kind of depends on the geography. I mean, you're right. It's still a problem, Kim. I'm not minimizing that in any shape, form, or fashion. That's a separate problem that goes along with not potentially having expertise and resources in some of those smaller places. And again, a lot of this care is regionalizing because of that. But there may not be a single right answer to fit that because there are problems with both models. And believe me, you can see problems with both models. And again, for me, it's a little bit odd just because of how I practiced my entire career, right? But I am a little bit anomalous. I mean, we don't see a bunch of people who do high-end limb revascularization work, usually in small community places like that. So there's going to be a liability no matter how you slice it. And really, in my view, the probably optimal solution is to maintain local care options, but have policies, procedures, transfer pathways, and going back to what Andrew was talking about. Before you do it, and it's the ARC again, right? Before you do a non-traumatic amputation, mandating that there is a vascular evaluation, because if that occurs, that's going to change the pathway for all of these places because they simply won't get reimbursed for it. Right. And remember, hospitals.
That's important.
Yeah, Kim,
again, hospitals they're not care enterprises; they're business enterprises, right? The 3 physicians on the line, we provide care. We're not business enterprises.
And you have to take into consideration, for instance, I'm in a 29 hospital system right now. And we, even though the model is try to keep care locally, I can tell you I do limb salvage procedures at one of our community hospitals, but they don't have the same resources. They don't have the same equipment. It'd be a little bit dicey. And the problem is that their chief medical officer is incentivized to keep as much care there because they're competing against all the other hospitals in the system. So it's not a great answer. There's not one way that works for this. And as you also probably have heard many times, transfer to the main hospital. We don't have any beds. We don't have enough beds.
Yeah.
We have that same. Yep, we have that same problem. Where we have a vascular institute, we're trying to solve it. Andrew, you had said as well, we're trying to work together, at least at our main hospital, to have 2 physicians determine, kind of like a tumor board. Hey, does that person really need a major amputation? But it's an uphill battle. And again, I part of the other issue too is these procedures take a long time. In the same time, it takes me to do a complex revasc. Somebody could do 3 heart caths and 3 stents, and I mean, like, there's issues. There's capacity issues.
Yeah, we had no staff. We lost half our staff, so we had to stop doing procedures at 6 p.m. last night, other than the call team. Well, this guy's on deck for a debridement on Monday, and don't have a choice other than to do a revast today.
Yep.
Well, and that also
for you.
highlights why it's so important that we have all these sites of services engaged, right? And this is something that I think has been a real change. I mean, the Society for Vascular Surgery Advocacy has come a long way. Like everybody's on the same page now. We need to get as much capacity as possible. So we've got the OBLs, we've got the ASCs, we've got the hospital inpatient, and trying to sort out where that work is best done, where the operators are, so that we get the optimal result. I mean, it's huge, and it's a challenge, right, for capacity in the United States today.
Yeah, and I do think, one of the things just for the non-physicians, I think is what is thankfully happening in this space is a much more cohesive approach between the groups. It's not just vascular surgeons versus interventional radiologists versus interventional cardiologists. I think we're starting to see a change in culture and in kind of more on, we're all in the same boat. We're all trying to fight the same battle. And it's better if we fight this as physicians together than apart.
Agreed.
Yeah, wholeheartedly agree.
So I think, and the same thing with going, and I think it was a message to Congress, because I think about, I stood out there and I'm sure Bobby had the same thing where I saw Habitat for Humanity and I saw a bunch of other groups kind of lobbying. And I thought, if AHA or ACC come in here and they're lobbying, I'm like, really what we need to do is stand together and we need to work together.
Well, that's been tough though, Andrew, because again, because part of this is if you take an organization, let's just say AHA, let's say SVS, just pick your organization. You will still ultimately need to have physicians that are willing to take that time away. In the case of the independent physicians, that's going to be time where that's just gone. So there's a practice management issue, right? As a solo operator, when I'm gone, nothing happens. September, my practice was in the red about $40,000 because of the advocacy work that I was doing, right? I'd actually loaned money to the company to make payroll that month, but I didn't get paid. If you're an employed physician, there's issues with call coverage, there's issues with the scheduling, there's issues with all the other things. So it's not in any site of service, and regardless of what the employment model is, you still have to have physician champions that can take the time and get there, because quite frankly, we're better equipped to talk about this than the administrators are. We have a very different interest, right? We know the nuance of providing the care, the complexity, how heterogeneous it is. What do we got to do to save a limb? And that's a very different discussion than, an administrator is looking at a dashboard of metrics and costs and supply costs and OR utilization times. I mean, it's not those issues aren't important, but it's a very different thing. So the advocacy really requires engaged physicians that are willing to take that time, again, regardless of what their practice modality is.
Well, I want to get to Jean. If we can get to a couple folks here. Jean is a diabetic educator and podiatrist. Dr. Chen.
Hi. I want to make a comment that I think patient education is very important, because when I was practicing limb salvage, I hear from colleagues, why are you working so hard trying to save that limb? Why don't you just let that patient lose that leg, because they're not adherent to therapy, their diabetes is not well controlled. But if a diabetic patient never had education or being given the tools to control their diabetes, I think that's not a fair statement. And I think both physician as well as ally health and patient education is very important to prevent these amputations from happening.
Agreed.
1,000%.
Yep.
Early, I think it's also, it's not just that, it's early. This is likely a contributing factor to why amputation rates are higher in Blacks and Hispanics than in whites, right? Is your education. How do you get this education out? Set food deserts. How do you get this education that, controlling your diabetes not only impacts your, risk for blindness and your risk for kidney, for renal failure, but it also, the patient I just worked on, end-stage renal disease, right? From diabetes, from high blood pressure, and getting that education early, even in the schools, talking about education and really managing disease care early, I think is going to be important.
I absolutely love that, because that's where hopefully my future nonprofit will be moving towards. So I really appreciate that comment.
Yeah. And I know that Douglas wants to jump in, and then I think Dawn, and I know that I don't want to take everyone's whole afternoon. This has been such a powerful discussion. Go ahead, Douglas.
Yes, this has been an amazing show today. I heard you say something that really struck a chord with me. I'm blessed I still have both my legs right now. But you had mentioned I'm in a rural area and I had a whole bunch of work done before I got to a CLI doctor and getting that second opinion. And I remember him walking across the room going, if I had saw you 2 years ago, you wouldn't have had these procedures because of the technology. So, it reminds me of what we do here, how much it is going to take all of us working together to make a change, isn't it? It's going to take all of us standing up and having our voices and 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 getting to that opinion in it.
Yeah, and I think that it's good for everyone. He ended up with stents, aortobifemoral bypass, axillary bifemoral bypass, and he was never even told that he had peripheral artery disease. He didn't find that out until he saw all of our good friend Dr. Craig Walker 2 years later, which is amazing to me. And so in his rural community, they just went almost, stents, bypass, and then told him, well, we can't do anything else. Every 6 months, these things fail. And next step is amputation. And Douglas, how many years has it been since you found us and found initially Dr. Walker?
It's been right at over a little 3.5 years, but that was
you kept
that
your legs.
when I went back to the original doctor, he just said, I got blood flow where I need it. See you later. You're good to go. Don't worry about it. And that was the conversation we had. And then I met Kim in this group.
Yeah. So we appreciate it. Yeah, we got to help more and more patients. And I think this is just the start. This is such a great conversation to get us started. What you guys did on Capitol Hill, amazing, great start. Again, Dr. Tahara, tell everybody how they can get involved. I know on the Cardiovascular Coalition's website, they have the ability for anyone to go on, and they have a form on there to find your local leader. And it's like a fill in the blank, and then like a drop down, I think it is, to find your local leader and then write your message and then submit it straight through the website, and it channels that message off to your local lawmaker. Is there another way?
Yeah, there is no, that's a great start. And those things get counted as basically inputs. So those congressional officers will look and say, we got 200 emails on this. Okay, but that's about the extent of that. Much, much more impactful. And I'm going to repeat what I said earlier, regardless of your political bent, these people work for us. They're representing us. So the answer here is become engaged with your local federal person, your congressperson and or your senator. It's easier to get into congressperson's office, quite frankly, than the senators because they do the whole state. But you can call and make an appointment and sit down and discuss these things. That's far more impactful when somebody actually makes an appointment and does that. It's extremely impactful when a patient does it, particularly when a patient has had a problem because they've had an access to care issue. It's impactful when a physician takes time out of their day to do that, right? They listen to that. And then again, the other thing is to become, regardless of your political bent, somewhat involved and understand the system we have it, regardless of what you may think of it, is if there isn't funding to get access to these people, and it's not a quid pro quo, we can go do a congressional event. It might cost $10, $20, $30,000 to actually do. They're not going to say yes just because you did an event. That's actually also a misrepresentation that comes through a lot because of some of the things that have happened or some of the ways that people look at this. But if you don't have funds to get access to these people, you don't get to sit at the table. If you're not sitting at the table, you're going to be served for lunch. So I think the take-home message for people who are invested and want to save limbs or don't want what happened to them to happen or don't want a family member or because you care for people like that is to stay involved and plugged in to the best of your ability. Call and bother your Congress critters, right? Participate giving to the PACs. The Cardiovascular Coalition is a wonderful organization, right? PAD Alliance, a wonderful organization. There's lots of ways to do this.
Yeah. So thank you so much for every one of you is doing to save life and limb on a national level. We really appreciate you. Let's keep this conversation going, and hopefully let us know when the next meeting is, because we might have more and more patients ready to show up on Capitol Hill. But thanks everyone for joining us, and happy Valentine's Day.
Thanks, everybody. Take care.
Thank you.